I'm trying to connect to Binu ma'am. I think some trouble is there from her side in joining in. So we can straight away, I think, start also. In case ma'am joins in, then in between we can just ask her to have some words over there on her
Yes,
side.
we'll start by 4 sharp. Yeah.
We'll start by 4 sharp. Right now, so it is not visible to the panelist. It's just between, sorry, for the audience, no? So once we start, Maling will be sharing the creative on the screen itself. All these speakers are done. We have from Abhinash side, is the screen, everything is okay?
Yeah, I'm not sure. Avinash.
Good evening, ma'am. I have logged in from hospital mail ID.
Okay, so nursing leadership is Avinash right now. Okay.
Yes.
All right, all right, all right. You will be sharing your content on your own?
Yeah, no, ma'am. I have shared this to Mahaling.
Okay,
So
he will
he'll
be
share
sharing
the
that.
slides with us.
Great. Right. So Ranjit is still
Ranjit is also there. No, Ranjit is also there.
is there?
Ranjit, you can hear us, right?
Yes, ma'am. Good evening, ma'am. Good evening, all.
Yeah. So all the panelists can probably come on screen. Yeah.
Super Maling.
Don't call it.
Great. So very good morning, good afternoon, all of you. 4 o'clock, and it's time to start the session also. Right.
Yes.
So very good afternoon, all of you. Thank you for joining in, logging in on time for the Ivy Talks May edition. I hope I'm audible to the audience as well. Can we have some hands, some thumbs ups, or maybe some raise hands, or maybe some yes in the chat box? Great. So welcome to the Ivy Talks May edition. We are having the Hyderabad team over there. As you all know, Ivy Talks is a platform exclusively for only INS India members. Every month we connect with different state chapters, speaking in, bringing in experts to continue discussions on the various aspects of infusion therapy in accordance with the INS standards of practice. Along with me, I have my teammates, Mr. Mahaling, Ms. Ipshita, and Mr. Shinoj. And the Hyderabad chapter would be, would be initiated and discussed, and the session, entire session would be moderated by the chapter chair, Ms. Sino Thomas, ma'am. So we're handing it over to Sino, ma'am, to take the session forward.
Thank you so much, Pooja, and thank you so much, Team Polymet, for hosting it along. And I'm sure those who have witnessed the last few months of Ivy Talks have definitely learned a lot. So first of all, a very good afternoon to all of you, and welcome on behalf of INS Hyderabad chapter. Thank you for joining us today for this panel discussion. And we are here today to explore bundle care and how it's impacting the infusion safety. This is a crucial topic because care bundles enhance safety as they are bundled and they are built on evidences and practice. So without taking too much of time, let me take this time to introduce our esteemed panel today, who have joined us with their extensive experience in their work. And I'm sure that they will be a great resource for our discussion, and our panelists will bring in the valuable insights on the selected topic. Right. Firstly, I would like to welcome Dr. Kaladar. Yes, thank you so much for joining in here. He's a senior consultant at Yashoda Hospital, Malakpet. And as you see over here with a lot of accords here, he is specialized in areas of ARDS, ECMO, toxicology, infectious diseases, and so many other areas. So I'm very sure that his expertise is going to give us an insight on many and multiple folds around it. He has been honored with the prestigious Dr. APJ Abdul Kalam Achievement Award for his noble service in healthcare, and commendably recognized as the best critical care doctor by the Eminent Doctors South 2024 from Health Magazine and Outlook Magazine. And additionally, in the position of executive member of ISCCM Hyderabad. Thank you so much, doctor, because the background of the clinician definitely is required to be supportive to understand those areas which nursing will help in bringing in the expertise into the intervention. Thank you so much for joining in. Our second panelist is Dr. J. Pratibha here today, who is a consultant clinical microbiologist at Apollo Hospitals, Jubilee Hills, Hyderabad. With the vast amount of things coming under her hand, we can all imagine how she will be able to, put across the thing. And we are really thankful that it's a different domain that we've been able to add it to our panel discussion today with a microbiologist on board. She bringing the extensive understanding on JCI, USA accreditation of the Department of Microbiology, being an internal auditor for NABL and as an auditor, and also been certified under trainings on HUNET and antibiogram preparation from WHO, and a member of Indian Society for Medical Mycology. I'm very sure that we will be able to get an extensive understanding from a different tangent altogether. Thank you so much, Dr. Pratibha, and we welcome you on the board. We also have with us Ms. T. Suman Ryan. So when we were looking at the panelists, we wanted to have a multidisciplinary approach towards this thought, because bundle is not just an understanding from infection control point of view. So we wanted a nursing head also to help us understand their areas. And we have here nursing superintendent at Skims Hospital, Kodapur, Hyderabad, bringing an extensive 23 years of experience. And she is an assessor for NABA associated with QCI. Also, she is a trained and certified in Lean Six Sigma Green Belt. So I'm very sure quality is the paramount for her, and she's instrumental in developing the in-house electronic health card records system in KIMS. So thank you so much for joining in, Ms. Suman. We have with us Mr. Geet Avinash. So he is a gentleman handling the quality perspective in AIG Hospital, manager nursing at the AIG hospitals. And he has a background in different areas, into clinical experience into ICU as a team leader with Continental Hospitals. And also he has done his post-basic nursing from the Lakeside College of Nursing. Additionally, he is also a faculty member for Stipend National Program for IDCCN, Nurse Across India, an initiative of ISCCM in 2022. With his experience, he is also going to enlighten on practically is this feasible, workable or not. So that's what we're going to hear from Avinash. And last but not the least, the last panelist with us is Mr. Sirapura Ranjit. Though he's introduced the last, he is the paramount in taking it further when it comes down to this topic. Thank you so much. He's an infection control nurse at Rainbow Children's Hospital, Hyderabad, and with extensive experience of 9 years with different areas of infection control, pediatric healthcare safety, and staff education. He has obtained certifications on infection prevention and control from WHO, as well as he's certified from CMC Vellore, Tamil Nadu. So with this experience, which is all around 50 plus years altogether put in, we look forward for a very productive discussion. Thank you so much once again, all the panelists, for consenting for this particular program and for the time that you're going to spend out of your busy schedules for us. Yeah, so without taking much of your time, I'll quickly come into the topic. So as the discussion is on bundles, now we have in our experiences seen bundles and implemented bundles in different arenas. There are fixed type of bundles which we all learn and which we place it to have our practices more efficient. Now we also wanted to think on, because concept of bundle in infusion safety is not very old, not very new, but there are some of them who are implementing, some of them for a completely new thought. So we wanted to understand how are we going to take it further. And really, is it practical to create a bundle and work on a bundle when it comes to infusion safety? So with this, my first question goes to Mr. Ranjit. What is the significance of bundles in vascular management?
Ma'am, thank you, ma'am. Good evening.
Okay.
One. When implemented, a bundle is a set best practices that when implemented together significantly improve patient outcomes. These patients are typically standardized and request consent application across all patient and healthcare providers. In the standard, reduction in medication errors, prevention of collapse or central related bloodstream infection, and central line associated bloodstream infections. Ma'am, in that practice recommendation, the WHO recommendations and practices the Infusion Nurses Society reflect a commitment to enhancing patient safety through evidence-based practices. These standards are crucial for clinical involved in infusion therapy across various settings.
All right.
And this central type of central venous catheter lines, PICC lines like peripherally inserted central line catheter lines, small bore axillary central catheter lines, small bore internal jugular central catheter lines, small bore mid-thigh femoral central line catheter lines. Marshall, PICC lines rather than peripherally inserted central line catheters end in either the superior vena cava to provide inferior vena cava, optimal positioning for the needed IV therapy. PICC lines are flexible catheters that are inserted into the vein in the upper arm in near the heart. Ma'am, I'm audible clearly.
Yes, yes.
And while we are using for TPN preparation, like total parental nutrition administration in the child, chemotherapy medicine can also used for certain intervals for shorter interval patients with the difficult vein access conditions. Should not be placed in mastectomy patients with lymph nodes removed. Patient with arm injuries or infections, those with vascular diseases will use in the vascular disease patient also. It is used for more longer period compared with the IV cannulations. And internal jugular lines are inserted into the jugular vein in your neck and at the heart. The catheters can be small bore or longer bore. Example, longer bore. Internal jugular central lines can be used from temporary dialysis, a quad lumen catheter that can accommodate simultaneously multiple drug administration that measure of central venous pressure. Femoral and mid-thigh femoral lines provides great comfort to the patient. Patient who have upper extremity trauma, new placed cardiac paces, limited range of motion are their conditions. We'll use mostly femoral and mid-thigh femoral. And key significations: infection prevention and control, improved patient outcomes, standardized care, enhanced monitoring and accountability, cost effective, and education and training tool.
Okay. Great.
See, what are care bundles? Care bundles are structured sets of evidence-based practices. When performed collectively, they improve patient outcomes. And evidence-based, each element is supported by high-quality research. Together, they create a comprehensive approach to infection prevention. The care bundle aim is mainly prevention of the infections. Like we are taking an example of a catheter-related bloodstream infection or central line associated bloodstream infections. Uh, we are proven by the evidence-based and implementation-based only through care bundles and improved outcomes. Bundles standardized care process. This reduces variation and improves reliability in healthcare delivery.
Right. So while you have introduced of what the care bundles are and how the significance is in terms of the different types of IV lines that we have seen right now, this is the right introduction to understand why exactly the extensivity of understanding is important. So my question goes to Dr. Kaladhar. Uh, what do you think? What are your thoughts on the effectiveness of bundles in improving the outcomes while the patient is in the intensive care unit? While you are looking at it, if you can cover all the gamuts, it would give a highlight around has really improved the entire gamut of efficiency.
Yeah, definitely. I think it's did. Am I audible? Yeah.
Yeah.
Yeah, definitely. Thank you, Sino Thomas, for asking that question. I think Ranjit started the introduction as rightly put by different how the bundle, what is bundle, and all definition is very important. So when we look at the bundle, it's a set of elements practiced together to have a very good, mean to say, in terms of the bundle care in ICU to prevent any infection. That is what we are worried most of the times, of course, from the infection point of view. Other than that, yeah, there are some other bundles. Yeah, overall, it all dated back. If you look at the history, Pronovost et al. Is the one. So matching Michigan style, we call it as. So he's the one pioneer started this bundle care when he was practicing in Michigan University, being a physician. So he could see that the patients who are put on central lines used to get the infection. The primary underlying condition, probably, suppose, for example, if you look at a patient came with ARDS, you put a central line, and subsequently after 3, 4 days, ARDS got improved, but later he could develop a new infection, new fever. When looked at the central line got infected, so he could see that there are some the problems which were not properly practiced. Suppose, for example, right from the central line insertion so to the maintenance, so he could see a lot of lapses in that. So because of which the patient entered into the patients, different patients entered into the central line bloodstream infection. So he could thought of that checklist versus bundle. As you know, checklist is like a checklist where everything will be in place and you check it and then practice, as compared to bundles where it is evidence based. So if you look at all these elements he put together and started to practice, so over, I think, around 18 months, I could see he was very obsessed about it. I mean to say, when you are practicing a bundle care, you should be really very obsessed about it, all or none phenomenon. You could practice practicing all the elements together very strictly. Otherwise, it's better not to practice at all. That much obsession was there with him. So because of which he could observe 66% reduction of the central line associated bloodstream infection, significant phenomenal change whatever he could observe. So that makes a stage where I think a fundamental way of how it started evolved together, expanding to other areas like ventilator-associated pneumonia bundle and other things. So this is one of the example. And subsequently also there are many studies and even meta-analysis which were shown that these bundle care, if they are practiced together, so there is a significant change. We could reduce the infections. At the same time, the length of stay, the mortality also in some studies improved, because as you see, suppose any patient lands up in a central and bloodstream infection, it is nothing but directly the bacteria going to the bloodstream. So it is devastating. It will add to morbidity. Sometimes length of stay may increase, number of antibiotics, so many complications, and then sometimes even mortality. The patient can go down with subsequently lands up in multiple organ dysfunctions. So such important thing that is. So definitely, I can say in my practice also, whenever we look at if there is a CLABSI case has come, we go to the root cause of it. There will be some labs, maybe the maintenance, maybe the insertion, somewhere the labs will be there. If everything is practiced in the right way, most of the times we don't get CLABSIs. So in my practice and even evidence-based, I can say the effectiveness of care bundles is very, very important. And definitely there is a lot of effectiveness by practicing these bundles together. Thank you, Sainath. So
Right.
that's all from us.
Yeah,
Yeah.
great. I think the study which you have projected here definitely tells a significant amount of difference that had. And you rightly mentioned that it has to be an obsession. It's not just a checklist which just gets filled, somehow, but it has to be an obsession, and people who take it should definitely look at it that if I follow it, a significant amount of preference I can make it in the patient outcome. Very well put, doctor. Thank you so much. Now when these parameters are discussed, under the microscope, when we come down in the lab, so this question is for Dr. Jamnada. So how do you measure the success? These bundle compliances have actually led into it, and what could be the lab values that are indicative to say that the management of the IV lines have not been compromised, or what indicates that it is compromised? So this is for Dr. Pratibha to help us understand it. Yeah, could you please unmute? I think, yeah, we can't hear.
Yeah,
Yes.
you can't hear. Am I audible?
Yes, you are.
Yeah. Thank you for the question, Sino. Now, I would like to explain it in a different way. We don't take only lab values to consider whether the line was handled correctly or not.
Right.
Right. So we always take the clinical condition of the patient, whether patient is having any infection at other side. So whenever we isolate any organism in our lab, when it's in hospital, we decide whether it is an hospital acquired bug or not. Whether if it is an MDR, we go back, we see if patient is having any infection at the other side. Okay. Now, when we look into it, as a clinical microbiologist or as an infection prevention person, so what I would like to tell here is go back, look at the condition of the patient, discuss with your clinical team, and then decide. And the next thing is what we look into is your procal and CRP levels, which will definitely help, and other sepsis markers. So now looking at the how effective your bundle implementation has been. So first thing is, whenever you're implementing any bundle, the first thing is train your healthcare worker. Train them correctly on the bundle practices. Check their competency. As correctly said by Dr. Kaladar about the checklist, there should always be a checklist available so that whatever practices are being done are correct or not. There should be an overview by the ICN. Regular audits have to be performed by the team, infection control. Whatever data is collected has to be analyzed, discussed with all the stakeholders. So all these audits, findings, discussions, loopholes, wherever there are the areas of improvements are there, have to be identified. And this, whatever the areas are identified where the improvement is required, has to be discussed with the team at the ground level. Unless we involve the team at the ground level, we will not know the outcome of your implementation of your bundles. So what will be your outcome? We basically discuss our bundle compliance in our meetings. So we discuss, and then we discuss about outcome, that is HI infections in a particular unit. What are the rates of infection, be it a CLBSI, VAP or 40. This is how we go about it. Thank you.
Great. I think a lot of insights around it. A lot of takeaways that training is paramount, and checking is the competencies have to be in place with the proper checklist in place, and this needs to be reviewed again and again. Overview has to be done by the ICN and the audits by the team. Also, the data has to be analyzed, and the ground team getting involved. That's really an important point. It's important that people who are really going to handle it, they should be the ones who have to be primarily into the picture. Thank you so much, Dr. Pratibha. So I would like to have Ms. Suman to highlight on now. There are different levels of team members that will have it in nursing. There will be some freshers coming in. There will be an experienced staff. There would be an mid thing. There will be a millennial person coming and working. Plus we have our leadership team here. Then you have ICN. So there are a lot of people who are also handling and touching the patient apart from the caregivers. Even the non-caregivers also touching. So how do you think, what protocols can be placed in order to have a better implementation on it from a nursing head point of view?
Thank you, Ms. Saino, for the question. And I must thank Dr. Pratibha as well because she has made my life a bit easier by answering, few of the points which I wanted to discuss. Now, to ensure the adherence to the, bundle practice, we need to have a strategic approach or a strategic workflow. Now, I would like to discuss on the strategic approach what we follow here at KIMS Kundapur. Now, a core principle for anybody to have something into implementation is training. So the training of nurses, like you have rightly mentioned, it is not just the healthcare workers who are, in contact with the patient, but there are housekeeping, other technical team as well. So training plays a vital role in the implementation of these bundle protocols. Now, is it the training only a classroom training? Then my answer is no. The training of established protocols needs to be done in a classroom training. However, simulation based trainings, which are my favorite topic, will help these nurses who had undergone this established protocol training, will, help them in putting those learned practices into learned protocols into practices. Now, is it the only people of level 2 and 1 to be trained? Then my answer is no. The nurses starting from the induction, we should orient them. They should understand that infection prevention protocols, the bundle interventions would play a vital role in the prevention of spread of infections. Now, after the training, I would say that, we can assign a bundle champion into each unit. Now, we have all heard of link nurses. Now, link nurses are helping us 24/7 to understand or to monitor the HIC protocols in each unit. So, I wanted to start this practice of having a bundle champion wherein um, they can focus on the implementation part. They can be a mentor in each shift for the nurses. They can also oversee what protocols are being followed by the nurses there. So assigning a bundle champion would really help, I guess, having this work done very well. Now, apart from this bundle champion, audits definitely would help us, have the insight of, the workflow which is happening at the unit level. We are training the nurses, but then when it comes to implementation part on a real patient, will only be understood when the audits are being carried out. So there has to be a structured format for the audits and which needs to be done randomly. Now, once the audit is done, it is time for us to analyze, take a feedback on what had happened in the audit. Analysis will definitely give us the area of improvement so that, we have an area to understand whether the nurses are requiring to be trained. Is there a need for the retraining? Now, with all these strategies in place, there is one more vital or essential parameter which every one of us must be understanding is to have a culture of safety. Now, there has to be this culture that, every nurse would come up telling us that, I did not practice this bundle intervention because of this reason, so that this non-punitive reporting environment can be created so that we understand that this particular nurse is requiring some helping hand in the implementation part. So these are few strategic workflow which I follow here at Kondapur unit.
Great, very well placed in terms of, one important concept which has come is like bundle champion. Yeah. Which could be there in all the 3 shifts, and there could be, so this mentee basically can, also overlook on the everyday practice and, help people, handhold people. And when you have different levels of competencies in team, then, their gaps can be identified and, accordingly in every single shift that can be, worked up with their hands together. And people should be encouraged to practice better in a non-punitive environment where the mind is free and they are more opting in terms of looking at right way of doing things instead of just being under pressure doing work. Thank you so much, Ms. Suman. think that's definitely a right thought process and an approach and a big team like nursing where we really need right understanding and empathy also to the team. These elements do work. So I would again come back to Dr. Kalanda, and I would ask you to help us understand. Of course, there are bundles used in ICU, so please give us a highlighter on what bundles are used there, and also what are the specific components which go into a bundle which could be used in the ICU, the bundles that are used in ICU rather. Yeah, yeah. If you please unmute yourself again, I think.
Yeah, yes, indeed. It's
Yes,
muted.
yes.
Sorry. So, practically, what we use, the most common bundles that are there are CLAPSI bundle and COTI bundle. That is called central line associated bloodstream infection CLAPSI and catheter associated urinary tract infection bundle COTI and VAB bundle, ventilator associated pneumonia bundle. Surgical site infection bundle. Yes, these are most commonly used bundles. Other than that, of course, there are some bundles which are not very standardized, but still we use like ABCD bundle and even pressure sore bundle. Yeah, pressure sore is also one of the important aspect of the quality that we see in ICUs. So if you look at CLAPSI, COTI, and web bundle, essentially always it starts with whether really the catheter is required. That is one important question. What I say practically most of the time at the bedside, even I discuss with our students and even with nurses. Always you assess whether it's needed. Suppose, for example, if you take a Foley's catheter, so the patient may be conscious. You want to monitor urine output sometimes, which can be put, but indefinitely it will be continued. So this type of approach is very important. So I think I will go one by one the bundle. If you look at the CLAPSI bundle, central line associated bloodstream infection bundle, where the insertion bundle and the maintenance bundle are there. If you look at the insertion bundle, always any bundle while putting like before starts with a good hand hygiene. So it is very important. Like some suppose there may be some juniors which are coming may not be go through the proper hand washing technique and follow the hand hygiene, the steps of hand hygiene, which is very important. I think we should be encouraging them to follow strictly those hand hygiene steps. And then full definitely going through maximal barrier precautions, something like wearing gown, even the mask and even the cap. Most of the times what I observe in juniors, I get they don't put the cap. They think it's not very important. And if you go to arterial line, especially something like a radial arterial line insertion, they think it's okay to just they apply some chlorhexidine and just go ahead with some sterile gloves. But it should be practiced like as we are putting a central line, even it may be a radial arterial line. So the hand hygiene, then full body drape and maximal barrier precautions to oneself. And then while inserting, chlorhexidine has to be used for a skin antisepsis, which has to be definitely a 2% chlorhexidine. So, and this is very important. Even some medium-sized hospital where I used to go, they practice still povidone iodine. It is generally out of the way. They will not give good antisepsis, and you should wait until it is totally dried out. So that is very important, crucial aspect. Then here comes which line is important. Avoiding femoral lines as far as possible is important because most of the times the femoral sites are near to the dirty areas where the possibility of collapse will be there. And then, of course, this while putting the central line is very important. Even dialysis sheets very important to follow this insertion bundle. Then maintenance comes where the transparent dressing has to be there. Daily inspection where we call it as the tegadam, whatever it may be, the transparent dressing. You should look at the incision where the central line has gone in has to be whether there is any redness has come up, whether there is induration, swelling, sometimes even pus. Sometimes to the extent the initially, if one able to pick up at the redness level, the infection will be in the initial stages. It has gone onto the level of the pus formation. That means the advanced eclampsia has already set in. So that is the reason when it is red itself has to be picked up. And then scrub the hub. Everybody know rub the hub or scrub the hub. with alcohol swabs is very, very crucial aspect. And the most common thing in practically what I observe is the central line, especially if you put on the right side, the patient on ventilator, and he will be putting his head towards the right side, the oral secretions will slowly they come down and then they cause the contamination of the central line site. It's a very common finding. We used to like now we are practicing if it is possible left side internal jugular vein because most of the times you see the patient's head will be turned towards right side where the oral secretion is not properly taken care will be contaminating the central line site. That can be one practice in my practical experience. And yeah, always whether this is really required. Most of the times, once central line, whatever catheter is put in, most of the people are comfortable with it, and then will not take it out if not needed. Probably secure the early peripheral line once the patient gets stabilized and remove it. That's a very important, crucial role. And most of the times, actually, central line is being used for sampling. Yeah, of course, there is some issue. There is some issue with the other blood sampling from the other side. Probably can be used, but we have to probably minimize frequent sampling taking from the central line. That is also very important because the intervention is happening more and more. The possibility that introducing infection will be there. Another important aspect when any patient, especially post-surgical major surgery, we do use TPN, the total parenteral nutrition, where the dedicated line, one line has to be dedicated to that human, whatever it is there, that has to go in that only. You should not be disturbed and put it in another line and all. Because see, when it is, because it's a lipid and carbohydrate rich solution, the TPN, very fertile soil for the bacteria to develop in that. That is the reason. So we have to use a dedicated line. Essentially, this is what the CLAPC bundle. And if you look at the COTI, as we discussed, like catheter-associated urinary tract infection, so this is also very important as the infection which if the patient develops, definitely it is going to be very bad. Then lands up in urosepsis and all if not taken proper care, especially the patients who are immunosuppressed and diabetics. So they tend to develop this. That is a reason very important. And here also the same again, it starts with the initial assessment of whether it's really needed. And then of course, very most commonly observed lapses in securing the Foley's catheter. Most of the people, if you just randomly check, most of the people take it light and they don't practice proper hand hygiene, proper meatal care while inserting the line. They don't put a drape, so these things are very, very common. Probably this has to be taken very seriously. More and more every day, if you tell, probably that happens. I in my experience, that's what I could see. So once it is being inserted, very important thing is it has to be secured to the thigh. It should not be moving around because once it moves around, the possibility of mucosal injury happening in urethra is more, which can cause the irritation, development of the bacteria in these patients. And another important thing is closed drainage should not be interrupted frequently. If it is interrupted, of course, the introduction of the bacteria into the catheter is more. And it should be well below the bladder level and above the surface, which is very important because above the bladder level, if it is frequently taken, the reflux happens and then possibility of infection will be there. And dedicated, the collection should be there. Dedicated collection, what to say, some bag or whatever, it may be jug, whatever. It has to be dedicated to one patient only, should not be between different patients. That is very important. And close the loop. And again, another important point, the old age, most of the times, while removing, yeah, always assess removing Foley's catheter. And while removing, most of the people still apply the clamp, should not be practiced. Everyone wants clamp to be applied, the sensation to be checked, and then remove. So, but this practice actually will not help. If you apply a clamp, what happens? You are obstructing the flow. The intention is non-obstructed flow. When you obstruct flow, the bladder is distended. Already after maybe 5 days, after 48 hours, there may be some biofilm formation. Again, same thing. It will get reflux through the of the urine towards the kidneys, and all the possibility of infection will be more. So I think this practice has to be, even the old surgeons, They just come at the bedside and just advise, clamp the catheter, check the sensation, then remove the catheter. But I strictly say, I discuss with them, this is the obsolete concept, sir. So we should not practice. Probably we should over and over again, if it held, I think other consultants also will buy to it. So that is very important, CAR-T bundle. And everybody know VAP. VAP bundle is also very, very important. So we do see a lot of patients coming out of the primary condition, then landing up VAP if it's not practiced. So again, very important thing here is whenever handling airway equipment, strict hand hygiene is very important. And we do practice closed section. I think that helps a lot because you'll not be frequently disconnecting and putting and whatever, see the gloves and all, which is contaminated, the possibilities there. And subglottic suction, very, very important. Subglottic suction, intermittent subglottic suction we use, wherein most of the times every second hourly we do subglottic suction. The subglottic port will be there where the secretions which are pulled up around the glottis will be removed out by the subglottic suction port, which will be additionally coming with other than the pilot balloon. Another important, crucial, important aspect is to follow cuff pressure checking. At least 8 hourly, it has to be checked, which has to be around 25 centimeters of water. Because the cuff is the one which maybe if you nobody looking at, it can get deflated and the secretions will seep down into the trachea and the lungs. So I make a habit whenever I go to a bedside, any ventilator patient, just check the cuff. Is it adequate? Just checking it, inspecting, you will be able to know. We do have a cuff pressure manometer where respiratory therapists go every 8 hours. I make sure they document it. So we have to follow that. Very, very important. And now the oral care, very important. There are a lot of debate happened. Of course, we used to follow oral care with chlorhexidine previously. Now it has been changed. We are using toothbrush or otherwise saline most of the times because in some studies, chlorhexidine proven to be if it gets aspirated, suppose while using oral care, suppose whatever the small amount of chlorhexidine goes into the lungs, it can produce chemical pneumonitis. The possibility that chemical pneumonitis happens with chlorhexidine has been there in some studies. After that, we slowly moving towards the toothbrushing method or otherwise using saline to toothbrushing and saline and just suck it out. That's how I think chlorhexidine is being replaced. At our center, we practice toothbrushing with saline. So this is very important. Of course, spontaneous awakening trials. Most of the times, suppose any patient gets better, you delay extubation, the possibility that the VAP, as the days prolonged on the ventilator, the VAP happens very, very, very commonly. So this is a VAP bundle. If you look at surgical site infection bundle, of course, this is also very important. Right from suppose if you take a case of CABG, whole body wash can happen, chlorhexidine wash, air clipping rather than shaving, which is very important because it causes skin irritation, bacteremia, and all those things. And antibiotic, very, very important. Most commonly, if you look at the complying with the antibiotic timing before surgery is very less. Even at our center, we are trying our maximum, try to get 100%, but here and there will be lapses. Exact timing will not be followed. It may be too close to surgery. It may be too already the duration might have elapsed a lot. So that's what happens with timing of the antibiotic. And if the surgery is getting prolonged, probably required another dose is also important. And post-operative also, the wound management and glucose control, very, very important. We have seen many patients, the glucose control is not bad, is proportionally associated with getting a wound infection. So especially the patients like CABG and all. So glucose control is very, very essential in these patients, pre-op, intra-op, and even post-op. Post-operative wound management is very crucial. So pressure sore bundle also is there. We had seen we had seen a lot of pressure sores prior when I came here. So we even had quarrels with patient attendants that they were telling that your ICU care is not good, because of which my patient landed up in pressure sore. See, you see nowadays the attendants and all, they know everything. Once pressure sore comes, there will be a lot of tussle. But the thing is, you should be very, very important. Everybody looking at the risk assessment of the pressure sore and whatever we call the position. If you look at the position change, second hourly position change will not happen very regularly, even though you say second hourly, it may be fourth hourly. Sometimes the people tend to forget whoever it may be. So we put a alarm in our ICU where every second hourly that alarm comes. So everybody, whoever needs position change at that point will be changed, maybe to right lateral or left lateral or supine like that. So this is very, very important. I can say pressure ulcer point of view. See this, yeah, of course. These are, I think these bundles are the one which essentially very, even like, of course, in these patients, other than pressure ulcer, ABCD bundle, we say, but essentially those components also like delirium management, sedation, vacation, all come as one aspect. So these are essentially the main bundles that we see in our ICU. And if practice it together, I can say it gives a very good quality care to the patients and good outcomes. Thank you, Simon Thomas.
Thank you. I think a big applause to you for covering so extensively all the practical impact, on every single bundle which is there. I think you have a request here in the chat box. If you could share the PPT, people will be, helpful. They will get those points because they are all practical points. I think when it comes down to collapsing the point which
Actually, I
you.
did not prepare the PPT in elaborate. I just expressed my practically what we generally see at
Yes,
bedside and all. If you want,
absolutely.
yeah, I will just if there is any
Absolutely.
PPT.
Yeah, because there's so many practical points. A simple point like, when you're putting a regular which direction, because yeah, if you take it as a left one, the right one will not have a. So these are all so very practical ones, and everyone over here who are practicing will keep it in mind. So conscious work towards it, securing the lines and working towards it, rub the hub. I mean, these are all very, very practical, doable ones, not just hypothetical thoughts, but ones which are to be done and, practiced. I'm sure this is one question is there in the chat box. Pooja, I'll take it because it will help in, just connecting together. Now, each shift we are cleaning the urinary catheter with normal line. Is it enough for catheter care? That's the question here. So I think since we've spoken so much, it's good to just,
I think I
address.
missed that point. Meatal care is very important. Of course, the same thing again. It's been replaced. We used to like maybe 7, 8 years back. We used to take meatal care with antiseptics, something like most of the times it can be povidone iodine or something like that. But it's been replaced now with normal saline. Yeah, of course, each shift taking care of meatus is very important because meatus is the one where that place is being dirty. Definitely, there is the biofilm formation, and otherwise the bacteria do develop and will subsequently go in and can cause. Yeah, definitely taking care of meatus is very important. Yeah.
Yeah. So the right type
Perineal
of
care,
reagent
meatal care.
has to be used. Yeah, absolutely. Great. So, so lot of thoughts, lot of learnings, and I think quite extensive to go into the depth of what we are currently doing. Thank you so much. So I come down to Ranjit, and I would like you to tell now when you're creating a checklist. Yes, there are different ways of doing it. What are the main elements and what are the elements which are pivotal? It has to be there in the checklist. So if you can cover that aspect, that will also be learning.
Yeah, ma'am. Most of the points are all session covered by Dr. Kaladhar sir. But essentially, elements of a care bundle, especially in vascular management,
Yes.
hand hygiene, reduce the transmission of pathogens when before I am touching the catheter site or performing any procedure, maximal barrier precaution during insertion, minimize the risk of introducing bacteria during catheter placement, chlorhexidine skin antisepsis like most effective antiseptic for reducing skin flora, use chlorhexidine 2% in alcohol are allowed to dry completely before insertion. Optimal catheter site selection, like preferred site, helpful. Subclavian vein in adults over femoral or jugular unless contraindicated. Reduce infection risk. Daily review of line necessity. Unnecessary catheter increase infection risk. Like one before research, we will use a IV cannulation until 72 hours. Nowadays, if no signs of infection, we will continue that. So rather than one more cannulation, we are the line of necessity, remove catheter as soon as it no longer needed. Aseptic technique during line access and maintenance include disinfection of hubs before access using closed system, regular dressing changes using sterile technique, proper dressing and side care, what includes uses of sterile, transparent, semi-permeable dressing, routine inspection and change when solid or loose, staff education and training, ensure all involved are in competent in best practices, documentation and audits. Purpose of documentation: monitor complaints with bundle components and improve practices through feedback. These elements can be tailored based on whether the bundle is for insertion, maintenance, or removal of vascular access. Some of the points like and key components infusion safety bundle also in the vascular elements like standardized labeling, ensuring all IV medication are clearly labeled to prevent administration errors, smart pump technology, utilizing infusion pumps program with drug labels to minimize dosing errors, education and training tool providing organizing education to healthcare providers and best practices and protocols, regular audits and feedback, conducting routine checks and providing feedback to staff to maintain a high standard of care, multidisciplinary collaboration, engaging various healthcare professionals in the development and implementation of safety protocols. Implementing in practice of infusion safety bundle, access correct practices, identify exacting gaps in infusion safety and areas for improvement, develop a standardized protocol, create and clear evidence-based guidelines for IV therapy, monitor and evaluate, ensure all staff are knowledgeable about the protocols and their importance, assess the effectiveness of the bundle and make necessary adjustment, foster a safety culture, encourage open communication and environment to report errors and near misses. Uh, and we are discuss related vascular access bundle like CRBSI, central line associated bloodstream infection. So in that elements, hand hygiene, maximal barrier precautions, chlorhexidine skin antiseptics, optimal catheter site selection, daily line necessity, also preventive collapse rate. This newly 2024 INS guidelines says among the 765 days, it is come to only one CRBSA infection. Uh, so we are going through evidence-based practices. It is good implementation.
Right. Thank you so much,
And
Ranjit, for highlighting that. We have two more questions in the chat box. We'll take it because it will give us a continuation of the topic. So here one question which has come is, sir, if there is a presence of halitosis for patients on ventilator in spite of giving oral care with saline water and toothbrush, is there any alternative for that?
Yeah, sorry, I was texting
Yes,
here.
yes. So there is, we have a question. We
Yeah.
have a question in the chat box. Yeah. So they are looking at an alternative if there is halitosis for the patient on ventilator in spite of giving oral care with saline and toothbrush. Is there any alternative is what they asked?
Yes, yes. Actually, yeah, there are, when we were using the chlorhexidine, there used to be like the bad breath, whatever halitosis we call, used to be less. Of course, when we switched over to the new practice, our the respiratory therapists and nurses also was telling the same thing, like previously
Yes.
when compared to chlorhexidine, the saline. But see, the chlorhexidine being in different studies shown to cause these chemical pneumonitis problem and even mucosal disruption in the oral cavity, which can cause worsening infections. Probably, I think the thorough oral care with the brush and with the saline, of course, it takes a bit more time. Definitely, thoroughly clean. Most of the times, it can be taken care. So maybe if it is most of the times, if it is superficially done and all, it can be the possibility of halitosis. And another thing is frequent, maybe if the patient having more secretions here and there, doing oral suctioning also helps keep like the secretions will not remain in the oral cavity over a period, developing more halitosis. So this can be taken care by that. And of course, every shift, at least 8 hourly, the oral care has to be practiced. Most of the times, the people practice daily once and all. probably strictly practicing every 8 hourly may help.
Yeah. I think if the similar question gets answered, the same answer would be there for the next question, which is there like if the brush and normal saline instead of chlorhexidine is used, but the patient is on ventilator, what should we do that time? So I think
Yeah. The patient on ventilator also actually it is more of the patient on ventilator.
ventilator.
So it's intended for the patients on ventilator because the once we put a chlorhexidine inside the mouth, we don't know. Suppose if there is a cough pressure, you are not monitoring properly. The chlorhexidine seeps down into the lungs, which can cause that chemical. That is the reason actually. Even the conscious patients, they will not aspirate that easily. So the patients who are stable, probably whatever you use, I think most of the times is not a problem. It is actually intended for the ventilator patients. So we have to use for ventilator patients.
Absolutely. Thank you. Thank you so much, Dr. Kaladar. So next, I would like to have Avinash come on board. Now we have spoken about the practice. We have spoken about how the implementation has to be and what are other things to be looked into. Now, from a quality point of view, audits when you're looking at from a leadership point of view, what audits has to be done? What are the things that needs to be validated? How these checks can be in place? So Avinash, if you can just come and help us out to understand that perspective, so that another group of people who are also monitoring, who are also looking into day-to-day functioning will be able to have an understanding that these are the elements also to be kept in mind. Yes, please. Yeah, just unmute yourself, please.
Am I audible, ma'am? Ma'am, am I audible?
Audible, yes.
Yeah, thank you, ma'am. So we have covered the major practices under bundle care. Dr. Kaladas sir have told very clear about CLAPSI, CORTI, SSI, and WAP. So I just wanted to talk about the unattended or least bothered, though it is not called as a bundle care. So far, we have not never called as VIP, visual infusion phlebitis, as a bundle care, though it is a checklist for us. So this is often forgotten under these bundle care practices.
So we
So
are
what I
losing you
want to
in
stress,
between,
VIP.
Avinash, we are losing you in between. Since it's important, if you probably can switch off your camera, I'm not sure, so that if that network can become better with that, could you just try that?
Ma'am, am I audible now, ma'am?
Now it is better. I think you should do it this way. Yes, please.
Okay, ma'am. I'll continue without camera.
Yes.
So, as we have discussed the major part of under bundle care practices, as Dr. Kaladas was talking about all CLAPSI, CORTI, WAP, and pressure injuries exercise. I just wanted to stress upon the often unattended bundle, though we don't call it as a bundle. Visual infusion phlebitis is a checklist for all the patients who are being admitted in the hospital and who are on to the peripheral inserted catheters. So why I wanted to talk about this is the peripheral inserted catheter for all the patients who got admitted into the hospital with 95% inserted with this. So I wanted to stress upon the best auditors for this observation for a cannula in regard to the phlebitis is a concerned staff. The first primary auditor is a concerned staff who is looking at the patient. So we don't do this under phlebitis. Although CDC recommends that all catheters can be placed for 5 days, but then our internal committee, infection control committee in EIG hospital states that 72 hours is the maximum time that the cannula can be there on a patient. So we do a regular checks. There is a audit being done by me. So we have initiated a quality improvement project under this prevention of phlebitis. So we have initiated this in the month of June 2023. So why did we initiated this project is because there are majority of the cannulas which are not reported. So the global guidelines and the policies tell that the phlebitis rate varies from 2% to 80%, whereas India in 2021 study, the percentage of phlebitis is only 41%. So we are not at all reporting. Majority of the cannulas are unreported. So in our AG hospitals, what we have initiated is we have initiated.
We are losing you, Avinash. We are losing you, Avinash. That clarity, in continuation, we are not getting when you speak. So the benefit of
And
the
we have
audience,
initiated.
can you come through your phone if that works, because you're only speaking? That also you can just try, please. Join the link through your phone while you speak.
Yes, ma'am.
We'll wait. We'll give him a
Yes.
minute, please.
Ma'am, am I audible, ma'am?
Absolutely. I think this is very clear. Please go ahead.
One second, ma'am. Hello.
Yes, please.
Yes, ma'am. So I am running a project called Prevention of Phlebitis from June 2023, ma'am. The main motto for this project for me to implement is our hospital phlebite in my hospital, being such a tertiary care with IP census of more than 500 to 600. The number of phlebitis what we raise in a month is only 2 to 8. So that is the average number of phlebitis incidents that we have. So such a big hospital raising numbers in less than 10 is it's not a very good thing. So we have initiated this project in 2023. So now, after all doing so much of efforts, after doing so much of trainings and multiple audits, and we acknowledge that our fellow co-champions do a 5 audits per day, ensuring that we cover 500 samples per month. So we do this audit properly in every day in all the hospital setting, and we do share these observations to the in charges and the staff instantly. So I wanted to tell that IV cannulas are not taken care so much because this helps in prevention of phlebitis, and even we have got hopsis in past 6 months. There are approximately 18 to 20 hopsis in our hospital in regard to poor maintenance of the cannulas. So if we can take care of the patient's cannulas, and then if we can do our regular audits, and if we can maintain them in every shift properly with all proper infection control practices, we can prevent occurrence of phlebitis, and then we can prevent the patients getting hopsis also. Thank you, ma'am.
Wonderful. I think the QIP that you have put in terms of phlebitis, clearly explains the very common problems which is faced everywhere. Like, no proper documentation of the VIP bundle, lack of the knowledge of identifying phlebitis, and underreporting of phlebitis, very, very important, because people don't identify it only as phlebitis. And I think when we are only talking about IV cannulation, there are areas when we do sampling. I don't know how much of us are very conscious when we do a sampling also, like, when we're taking a blood sample, that's just a single prick. But during that time also, there are a lot of things which we create, and there could be damage which is not at all documented, neither it is recognized, neither it is monitored later. So yes, improper maintenance of IV cannula and not following proper flushing techniques. Right, these are some findings which are very common there. I think as a learning we all can take that one of the bundles is VIP phlebitis bundles, which we need to follow for infusion safety. Thank you, Avinash. Now these challenges which he mentioned, and we see that the problems are over here. So my question to Ms. Suman is like, how do you address these challenges? And there are barriers for bundle implementations, such as there could be resource constraints, or there could be staff resistance, or any other thing which comes on board. So what could be the strategies, and how do you address it? Yes, ma'am.
So, resistance from the staff and resource constraints are, I must say, they are real world, challenges, which I'm sure every one of us at some point in time might have encountered. So, coming to the staff resistance, how I deal here, I would wanted to emphasize on. Now, identifying staff who are resistant is most important one. Identify them, speak to them one on one, understand what is the reason that they are not able to follow the bundle interventions. Now, the reasons could be either the knowledge deficit, and the other one could be a behavioral issue. Now, for the knowledge deficit, we can always retrain, re-emphasize on, putting them into trainings, both simulation and classroom trainings would help. But then, when it comes to a behavioral concern, it takes a bit of time to, get them into the practice of the bundle interventions. Now, behavioral issues can be sorted by, giving them a true benefits of for the patients when we follow them, or showcase them the, few successful stories which we come across in the hospitals where the patients got discharged without any hospital acquired infections. Now, apart from these, we can also motivate these staff by, recognitions and rewards. Maybe every month we can, circulate a bulletin showcasing zero or maybe least a number of hospital acquired infections into each unit, and whichever unit is scoring better can be rewarded, so that, it will really motivate them, to implement it. Now, we have discussed on the resistance, both a knowledge deficit and also the behavioral issues. Coming to the resource constraints. Now, resource constraints, firstly, I would wanted to speak on manpower resource. Now, I'm sure every one of us will never be having the ideal manpower which is required for a unit, because the occupancy can be unpredictable, your attrition can be unpredictable. We never know when do we replace a similar competent nurse in the unit. So these are real world challenges which, as a nursing head we come across. Now, the solution for resource constraint in terms of manpower is only the optimal utilization of staff. We can, have competent nurses pulled in from other critical care units, and then, give them a helping hand so that this issue is sorted. Now, speaking on resource constraints related to material which is required in terms of patient care. Now, here at Kondapur, our infection control nurse is so empowered that she reaches directly the high leadership, or the top leadership in the hospital to escalate the matter, so that, their intervention can, sort the issue. And also, during our HIC committee meetings, these unavailability of resources can also be discussed, so that, there can be a proactive approach towards such incidences in the future can be prevented. So, yeah, this is my take on the question. Hope I have answered you.
Absolutely. I think a lot of important aspects from a leadership point of view, and specifically empowering the team who is handling it is very important. And identifying the deficits which are there in both the domains of knowledge as well as behavior, and then have specific interventions for both, because everything is not going to be, given a solution if we generally tell them about the perspectives and the success stories. Any positive reaffirmation is always helpful. R&Rs definitely go a long way, and they should be very loud. A good practice done by anybody which leads into a good patient outcome should be more louder than any other applaud. I think that's great. And if we have rolling trophies, as you mentioned, in units, so every single unit competes with the other to be the better one every single month. I think that's also something which definitely can enhance into the and then remove the barriers which are there. Thank you so much, Ms. Uman. I think we have a QIP, so I request Ashish to present the QIP, after which we can also take the questions which are there in the chat box. Over to you, Ashish. So, Malingam, you can display it while you can speak it from the phone. Yeah.
Hello. Ma'am, as I initially told that we have started a QIP, can you display the QIP, please?
Yeah.
So the main goal for me to start this project is to improve the patient safety and prevent by prevention and early detection of the phlebitis. So it was initiated in the month of June, and the main rationale for the choice of project is to ensure that there is a decrease in occurrence and to approach successful eradication of phlebitis in the hospital. So we found an opportunity by early identification, prevention, and managing the patients with phlebitis. So after knowing that what is the root cause that has been leading us the unattended phlebitis and unreported or early detected phlebitis are there is no proper documentation of the VIP bundle, which is leading to occurrence of the phlebitis, and there is lack of knowledge in identifying the phlebitis. They doesn't know what core score falls on to what. Suppose if there is a redness, they are not able to differentiate the scoring of the tool. So it is also an improper maintenance of IV cannula, which is leading to infective and mechanical phlebitis. So, and they are not following proper flushing techniques. So we have done a pre-study. Under that, we have done a knowledge assessment to the staff, and then we have done a point of prevalence. So in point of prevalence, we have found that the IV lines which are secured to the patients and the bottles which are connected to the IV stands are far. So they are each time whenever the patient moves from one side to the other, the line is being dragged because the bottles of IV bottles has been secured very far from the patient. So that is one of the chance for mechanical phlebitis, and the extensions which are secured is not secured properly. Since the weight of the extensions are more than the cannula which is secured in the IV line, that's just hanging off and it's dragging off. So it is also one of the main chance for occurrence of mechanical phlebitis. And then we often seen in our point of prevalence that wrong site selection has been done. As we all know, the guideline states that vein and the cannula selection should be 2:1. But then we have seen that the 18 gauge cannula has been secured to the metacarpal area, which is almost equal to the size of the cannula. Next slide, please. So after doing a pre-study, we understood what is the current process that the staff are following in a hospital sector. So we understood that their proper insertion and maintenance checklist cannula has been done at the time of insertion. Initially, before the EMR has come, we have a hard copy where VIP checklist has been designed with the front page of all the insertion details and back of the page is all the maintenance details. Now we have a provision for EMR that all the cannula related details has been documented into one widget, and with a single click we can see from the time of admission till the time of discharge about all the cannula details. And we have observed the site in every shift for any sign of phlebitis, and they have documented accordingly. And then after knowing the current process, we have initiated a J loop technique by which we are securing an external next to the cannula. So the current process at that time when we do an audit, the staff used to open the cap of the cannula and they used to secure it into the cap. But then each time they handle the cap or try to open the cap from the cannula and then they do, there is a major chance of the cannula to be misplaced. So that is one of the reason for mechanical phlebitis. And then scrub the hub whenever it is required. Often they are not following it off. So we have initiated a videos how to scrub the hub for at least 15 seconds and allowing it to dry, and then how to secure a semi-permeable transparent dressing. They often used to block the site of insertion, and then we are unable to do an audit. What is the cannula and how is the cannula was? Does the patient have any hematoma or any redness or swelling? Because they often block the cannula. And then flushing the line with following sash techniques. And the major concern is underreporting of the phlebitis. After understanding the current process, we have made few initiations, and those initiations are bringing up training sessions into the practice. So for all the new joined staff, we in induction itself, we are training them about the phlebitis, what are the prevention things that we have to do phlebitis, and then we are giving an OSCE session for all the new joinees, novice nurses, a hands-on session that on a dummy arm they do cannulate the patient, and then we ensure that full session has been taken for them. And we have also developed an educational videos to the organization, our education team, and we have made few videos in regard to scrubbing the hub, and then how to secure a J loop for the extina, how to do a semi-permeable transparent dressing securing. And then we initiated an IV team with a 60 member, and these are all the leadership team. We do monitor the patient from the time they insert the cannula till the time the cannula is been removed, neither discharged. So that is how we do audit, and then we also share an audit observation by the QIP co-champions instantly, and we do repeat our observations at the end of the month, and then we present into the QIP meetings. So after initiating all these new interventions, now after 1.5 years or so, our audits are still continuing, and we achieved a compliance of 97%. So next slide, please. So upon conclusion, I just wanted to show or highlight what are the implementations which we have taken in regard to prevention of phlebitis. Is first one, quality improvement program, and we have revised IV medication labels by which we on which we have started writing what is the end starting time of the infusion and ending time of the infusion, the diluent name of the drug, and then the dosage of the drug. And then we started monitoring hopsis as the rate of hopsis has been increased in the last 6 months, approximately till 18 to 20. And then we started using pre-filled syringes for all the cannulas, whatever the line that the patient might be on. We mandatorily made that 100% compliance will be followed in regard to pre-filled syringes. As I discussed, IV cannulation team, and we also do a safe medication practice audits every day. So each station has been audited at the time of medication loading, and we also initiated J looping technique to prevent the mechanical phlebitis by the poor usage of extensions. So to the cannulas where we insert at the joint spaces, so we have started using of splint irrespective of any age group. So we also do point of prevalence in between, and then by this, now we have achieved a good compliance rate in our QIPMM, and we are still continuing it. And we do take up this continuous until it is achieved a good number of high compliance.
Wonderful, wonderful, Avinash. I think there's a question here: how does bundle care contribute to patient outcome? This QIP definitely highlights the the different points there and answers this question as well. Like how it can significantly make a difference when you use bundles into care. How significantly the outcomes can be improved, right?
Yes, ma'am.
So with this, we come up with the end of all the questions that we had for our panelists, and bringing down to voice down all the thoughts across here, and wonderful questions also. Audience has been really participative and engaging. We have one more question here. We will just take it because it looks very simple question, but I will ask Dr. Kalada to please answer this question. Is it recommended that the betadine mouthwash diluted with saline is accepted for mouthwash? So, so I request Dr. Kalada to address this, since we have there were a lot of questions around this. Okay. So what we will do, probably if we are not able to address it also, we will make sure that we are able to get back to you on the answers of these questions. And if anybody else who would like to highlight it across from the panelist.
Yeah,
Dr. Kalada is there. Yes.
yeah. There was some call. Okay.
No worries.
Yeah. You asked about like the same saline and
No,
mouthwash.
here they're asking whether the betadine mouthwash diluted with saline is accepted for mouthwash.
Yeah, probably. Yeah, definitely. The idea behind not using a chemical is if it gets aspirated, it will cause the ARDS picture. See what happens, chemical pneumonitis, any chemical, whether it's a betadine or which contains povidone iodine or otherwise chlorhexidine, definitely the possibility of aspiration into the lungs can be there. So the intention is to prevent that. So probably it has been simplified that not to use any chemical to oral care, especially the patients who are intubated, because these are the sicker group of patients, and they have decreased immunity, and already like upon and their epithelium, especially the lungs and all, are very sensitive. Probably if this chemical gets aspirated, the probability that it can cause ARDS picture is been documented in some studies. From there, it's been published in General JAMA, actually, Journal of Association Medical Professionals. So where it is one of the high-rated impact journal. So it's been practiced that better to use only normal saline. As we practice, like in Carty bundle, where meaty care is being taken care by the saline rather than the chemical, because any chemical is an irritant. So more and more use. Suppose the patient is there for 10 days, use 8 hourly shift with chemical. There is a lot of mucositis also can happen, and the chemical can go down. This leads to complications. So that's what they observed in different studies, latest studies. The previous studies, they stressed upon chlorhexidine because it decontaminates the mouth. The possibility of the mouth organisms going down to the lung will be less. That is a different contention. But more and more, the latest studies show that these chemicals can cause more mucosal damage and can seep down, causing chemical pneumonitis. That is the reason we moved away from chemical to non-chemical based, which is nothing but a simple normal saline. So yeah, the concern of halitosis and all there, but probably frequent mouthwash can take care of that.
Yeah.
Yeah.
Very true. Thank you, doctor. Thank you so much once again, all the panelists. And this comes to the end. I think we have answered all the questions also. The audience was wonderful. Thank you so much for your active participation. You do have one more question, I guess. For that question, we have time, 1 more minute to go. Probably we can take that question. What is the question, which is, what is the best practice for police care cleaning with soap and water or normal saline?
Yeah, I think normal saline. Same. Again, boils down to chemical, non-chemical. Normal saline doesn't
Yeah.
it's natural, like we can consider. So mostly
It's like
the saline
when
is the best.
choose. Yes, please.
Yeah, that's it. Yeah.
Yes, Dr. Kaladhan, please continue.
Yeah,
I
yeah.
really. So shall I go
Yeah,
ahead now?
it's normal saline only. Yeah.
One moment. Yeah. Yes, Dr. Kaladhan, you can continue.
Yeah. Are you able to hear me? Yeah.
Yes.
Now it's fine. Yeah.
Yes.
So definitely it's a normal saline only. There also the same thing rather than soap and water. See, normal saline is better. And normal saline, if you see, it comes in sterile bottle as compared to the soap and water and whatever we use. We don't know the sterility of that. So that is also one of the reason probably it's better to use the normal saline where it comes in a sterile bottle. We may it's concluded that that contains no bacteria. So the possibility of contamination will be less. That is also one of the factor. That's the reason we use normal saline.
Yes, great. So quite rational questions and definitely relevant and practical answers. Yeah. So with that, we come to the end of this IV talk, and I'm very sure that it was very engaging. For me, it was personally a lot of learnings and lot of reiterations of some things which we were doing as as a bedside care people, and I'm sure everybody must have learned around it. So thank you, and over to you, Pooja.
Thank you so much, ma'am.
Yeah.
And thank you to all the panelists, all our esteemed panelists for the insightful discussions. And I'm sure the audience and all our INS community has got a lot of benefits from the session and discussions. Also, there is another important announcement for all the members. The next IV Talks would be hosted by our Mumbai chapter. So please do log in and keep sharing your feedbacks in the feedback form. The idea is to make these sessions more relevant for our day-to-day practices and the implementation of the INS standards also. As many queries were there when we take up the INS membership, as in what and all benefits do we get out of taking the INS membership. You can always reach out for expert advices as for discussions. One of this such initiative from INS India is the IV Talks. So please do get engaged in the IV Talk sessions. Please be participative. If there is any question which has remained unanswered, you can always reach out to us and you can always email to us. We can get you connected to the panelist and we'll get the answers for you on that. There is a feedback form link which has been shared by Ikshita and Shinoj in the chat box. So I request all of you to please share your feedbacks. There is a question which also says that what topics you want to see in the upcoming IV Talk. So if you answer that, most likely that session would be a part of the topic would be a part of the next further coming Ivy Talks. It's a fully calendarized event. Next is Mumbai, so looking forward for the connect in the next Ivy Talks, probably in the last week of June. Maling, you want to say something?
Nothing. I really want to sincerely say thanks from my bottom of heart to all the panel members. And it was very short notice time for all the panel members, but they have taken out of their schedule, busy schedule. Thanks for all of the panel members for making themselves available for this event. I have one question actually. I got a direct question from one of our panel. Audience. So just wanted to know that is there any correlation between CLABSI incidence rate and the biofilm formation?
Yeah, yeah, that's Ladri here. So definitely, yeah, the biofilm is nothing but the inside of the catheter. So it can be like the bacterial contamination can happen from extraluminal or intraluminal. So the biofilm is nothing but the aggregation of the bacteria within the lumen of the central line. So the more and more the catheter stays in place, the possibility of the biofilm formation can happen. It is something like suppose the infection can be elsewhere, somewhere urinary tract or lung and all. The bacteria can enter into the bloodstream and can come to the catheter, and they can also form the biofilm there itself. And if it is externally, suppose there is infusion which is not being taken care, sterile precautions and all, it can also form the biofilm. So the generally in ICU, when we look at if it is more than 2 weeks, the possibility of the biofilm formation is bit more. And in these patients, the possibility of patient landing up in CLABSI is also more, especially if the patient is receiving the high-end bacteria, antimicrobials. These patients are more prone to develop biofilm formation, and even the fungal infection, something like a candida and all. So the duration of the catheter depends proportionally towards the biofilm formation. And we do see patients with permacats, the permacats for dialysis, the Hickman catheters for oncology patients, something like chemotherapy and all. These patients have a prolonged periods of catheter stays in place. They at most take care of those catheters. So in these also the possibility of biofilm formation is high. Unfortunately, in these patients, we do practice antibiotic lock therapy where because the securing cannulas in these patients is a bit difficult thing because they do have access issues and all. So definitely, regarding biofilm, yeah, it's very difficult. Once the biofilm forms, eradicating the biofilm is a difficult thing. That is the reason whenever we get any infection, suppose there are no access issues, we just take out the catheter as early as possible to prevent CLABSI worsening further, or otherwise the patient landing up in CLABSI. In my ICU, for example, if you look at probably day 10 onwards, I will just suppose the patient there for prolonged periods, day 10 onwards, I will start looking at whether really the catheter is required for this patient. Support is required, probably I err on the side of changing catheter to another location if it's required. If it's not required, secure one peripheral catheter and take it out. So that is how the duration I can say is the thing which can depend on other underlying patient conditions like immunity and the prolonged stay, the infection elsewhere, the sterile precaution being followed, maintenance bundle of the line followed. These all also contribute to that. Yeah. I hope I answered the question.
Yes, sir. Yes, sir. Really, thanks for your brainstorming session. Actually, thank you, sir. And one more
Thank you.
last question from one of the audience. Actually, it is for I think it is for Avinash. I think. What is the most common? You already discussed about KIP implementation. What is the most?
Maling, you're muted. You may need to unmute yourself.
Mahaling here.
Okay, sorry. It is for Avinash. So just wanted to know what is the most common reason for premature removal of cannulas, peripheral catheters.
Can you please tell me again? What is the reason for
What is the most
Yes.
common reason for a premature removal of peripheral catheter?
premature removal? Okay, the most common reason for this is there is concentrated drugs that we administer on the patients. So that is the first reason. There are like I got it. So one is about the flushing. So we do follow a SAS technique called saline administration of drug and then the saline. So if we follow this technique at whenever we administer any medication, so we will hold the line and then we will prevent the line from occurrence of chemical phlebitis. And then whenever we administer any drug, we have to follow the push pause technique all the time, because and this is also sometimes not followed, so that this will also leads to the cannula blockage and then finally ending up in phlebitis.
Yeah, thank you, Mr. Avinash, for insight.
Thanks, Mahaling. We have got actually many questions, but I hope in the interest of time, we would be reaching out. I think Mahaling is there, so he would be reaching out to the panelists with the question, and I'll request the panelists to please help us out because around multiple questions are there. So for the audience, it would be always good if you can put the questions directly either in the chat box or in the Q&A box. DM questions gets answered always towards the end. So that may be a reason why the questions are not taken up right now. So please, Maling would be reaching out to the panelists with the questions and we will come back to you with the answers. Your email IDs and phone numbers are there. So the questions will definitely be answered. Uh, in the end, I would like to thank Saino ma'am also for being the wonderful moderator for the session. I think it's the moderator who brings on all the questions, all the essence of the topic which is being in there, utilizing all the panelists to the best of their abilities. So thank you, ma'am. Thank you, all the panelists. Pratibha ma'am, Dr. Kaladhar, Suman ma'am, and Avinash. And where is Ranjit? I can't see him, but yes, Ranjit also. Right. Thank you, everybody. We'll see you in the next session of Ivy Talks in the month of June. Thank you.
Thank you very much,
Thank you.
all of you.
Thank you.
Thank you.
Bye-bye.
Thank you so much.
Bye.
Good day.
Thank you all. Thank you all.